Get ready to invest in yourself and elevate your expertise with the Perio School podcast, brought to you by Perio School. It's Dr. Reena here, and you're joining us for a new monthly show where we'll be providing the latest case studies, first-hand insights, and interviews with our global dental network. Plus, we'll enable you to experience exclusive behind-the-scenes highlights straight from our global portfolio of courses. Let's get started. This season of the Perio School podcast is sponsored by Colgate. Register on Colgate's professional education hub to access all professional and patient resources, including your one-stop shop for all verifiable ECPD. Visit www.colgateprofessional.co.uk today to sign up and register. For this episode's mini masterclass, I really want to delve into risk factors because this is becoming more and more important in Perio. And I always say to everyone, I really do see us as detectives. And you've really got to do your detective work to holistically understand the patient and treat the patient to get the best results. So what do I mean by that? Well, perio, as we know, is more than just biofilm or plaque. Obviously, that is the key factor that causes the periodontitis or the gingivitis itself, but it's the risk factors that exacerbate the condition. And the way I like to think about it is when your patient is sitting in your chair, they have a little causal pie above their head. And it's our job to figure out what are the slices of that pie. So one slice could be biofilm. Actually, one slice will be biofilm. But what are the other slices? And those slices will be different for different patients. So it could be diabetes. It could be undiagnosed diabetes. It could be stress. It could be other medical factors. It could be pregnancy. It could be anything. And I think it's really, really important that you are a detective. You find those slices of the pie, because if you don't, you'll miss things and your treatment will not be as successful. So in today's mini masterclass, I just want to briefly talk you through the systemic risk factors which will play a role in periodontitis and the way you pick these out. Because in practice, we don't have lots of time. So how can you pick up these risk factors in an efficient manner? So I would start off, it's all in history taking. I would start off with your medical history, and the key ones to be aware of are diabetes, pregnancy, immunodeficiency, and then also any medications. So diabetes by far, I would say, is the most important medical risk factor. And the first thing you want to know is the type of diabetes, but also more importantly, what is the level of control? And I remember when I first graduated, I used to ask my patients, oh, what's your diabetes? Is it well controlled, etc.? And they used to all say yes. And I told my VT trainer, it was VT in that time, obviously DFT now, but that VT trainer was like, are you sure everyone's well controlled? What are you actually asking them? And I said, I'm just asking them if they're well controlled. And he later said to me, Reena, that is not the way to do it. You need to ask them their HbA1c. And when I did, most of them, the scores were through the roof. So I think it's important you ask them their HbA1c, which is a measure of the 3-month control and should ideally be less than 6.5%, or they've recently changed the units to millimoles per mole. So anything 48 or 50 and below is okay. So ask them that number. Either they'll know it from their recent blood test, you can call the GP, get that information, especially for a significant perio patient, because if that's through the roof and then you're trying to figure out why your treatment's not working and you think it's because of oral hygiene or something else, actually it's a diabetes. So yeah, diabetes, I would say, get some more information on that, figure out, the level of control, the medications they're taking. Keep it positive though, and try and include stats like, for example, if we can do some good gum treatment for them, we can actually improve their HbA1c by 0.4%. That might not mean much to them, but what it means and what you can say to them, it's clinically equivalent to adding a second drug to their diabetes regime, which is hugely significant, right? Would you rather have one round of gum treatment or be on another medication for the rest of your life? I know which one I'll pick. So diabetes is a good one. Pregnancy is another one to be aware of. Obviously, sometimes pregnant patients are very worried about having treatment, so you've got to reassure them that if they then do have perio, it's actually safer to treat it than not treat it. But pregnancy, everything becomes a lot more sensitive. I mean, I've just had my second baby, and first pregnancy, I got perio. Second time around, I was overly cautious and I didn't have any problems. But even the people with really good oral hygiene, everything becomes a lot more sensitive. Everything's magnified. They're more likely to get changes. And classically, you either get proliferative changes, so like that classic pregnancy epulis, or you get like edematous changes. When you're probing, you'll notice a lot more bleeding. So be aware of that. But again, reassure the patient, treat the perio. The only thing I'd really avoid is surgery. Other things in the medical history, like immunodeficiency, thinking about things like HIV, AIDS, but also just like things that are going to reduce the immune system, run down patients who are possibly also smokers, high stress levels, and then also have suboptimal oral hygiene. Those are the style of patients that are going to get things like necrotizing periodontal disease. So you may not get your classic periodontitis, so maybe a different type. So it's just something to be aware of. And necrotizing, remember, it's that pseudomembrane punched out papillae, halitosis, and that is the updated terminology, necrotizing periodontal disease. We don't call it ANUG and all those other things. It has been updated. And then finally, in the medical history, medication. So certain medication can cause gingival enlargement in certain individuals. So we're thinking about things like amlodipine, I would say, is probably the most common hypertension drug, anything with a dipine really at the end of it. And sometimes it's not just the medication, it's the dosage. So I've often seen patients where they go from 5 to 10 milligrams and then it has a response. But not everyone will get that change. But definitely ask about it. The biofilm is still the main factor. But of course, if they are able to change the drug, then that's something to discuss with the general medical practitioner, possibly write to them. So that's your medical history. Other risk factors to be aware of that might form a slice of that pie under your family history, of course, is genetics. And interestingly, 50% of periodontitis susceptibility is due to host genetic factors. So one of the first things I actually say to our patients is perio is a really unfair condition, right? Most of the time, it's not really their fault. And by the way, patients really love it when you say that, because then they don't think it's their fault. You don't think you're blaming them. They're more open to actually want to discuss it, and they feel better about it as such. But obviously, take family history with a pinch of salt. If they say to you, their 70-year-old mother has lost all their teeth, not so sure about that. But if they say, for example, they've got a sibling who's 32 years old who's having surgery for perio, I would take that seriously. So that's family history. And then under social history, you'll pick up risk factors. And I think the key one under this category is smoking. And I would look at the studies, and the most popular one by Tomar and Asthma 2000. And that study says that 42% of periodontitis may be attributable to smoking. So it's a big one. It's bad news really all around for perio, because they're more likely to get it. It's more likely to be severe. Treatment's not going to work as well. And even if it does, it may not last. So there's going to be poorer success all the way around. So smoking cessation is definitely something you want to be implementing. And don't underestimate your role. Even just a minute's worth of intervention can have a high chance of that patient then stopping smoking. So don't underestimate your role. Get them to use the smoking cessation services. It actually triples their chance of quitting. So, and keep it positive. Focus on the advantages of quitting rather than the disadvantages of not quitting. Vaping forms a part of this, and this is probably what you're thinking. What about vaping? We don't know as much about vaping, but at some point, vaping cessation should form a part of your treatment plan. Of course, some smokers use vaping to stop smoking, and actually it's a very successful and efficient tool for that, because it's one of the only smoking cessation tools where it actually feels like you're smoking. But obviously, it's probably going to have some effect, so you want to, long-term reduce and stop vaping. And finally, under social history, stress. Don't forget about stress. A lot of people are stressed right now, and stress can affect, it's two things. It can affect your immune system, but also it has a behavioral effect, right? If you're going through a divorce or moving house, you're using your interdental brushes is probably not going to be your priority. So, and then also it's linked with other behaviors, right? If you're stressed, you're going to drink more, you're going to smoke more, all those kind of things. So we talked about medical history, spoke about social history. The final one is dental history. And this is where you can pick up things like diet and nutrition. And really, this is quite a hot topic now in terms of perio nutrition. But think about key deficiencies. And things like vitamin C, vitamin D, certain antioxidants, all those things, they do have a role on perio. High carbohydrate-rich diet, that's going to increase inflammation. All these things you want to definitely be aware of and make sure we encourage a well-balanced diet. Diet modification is preferred over supplements, and so that's something to consider. But definitely it's worth bringing into play. So I would say definitely look back at your templates, look at your history taking. Are you asking about these risk factors? Because if you're not, you may be missing parts of this pie. And it doesn't have to take ages. It can be a really quick fire round of questions to your patients. But for perio patients, it's absolutely key. So see how you can add that in. They're your key risk factors. They're your key systemic risk factors. Of course, a Perio then also will have local factors, and you can really go down into detail in terms of things like crowding, anatomical factors, mouth breathing for certain restorative overhangs, open margins, etc. But I think my focus for today's mini masterclass is systemic risk factors, being a detective, treating your patient holistically to get the best results. So now we're going on to our case discussion section. And this is always one of the highlights of these episodes, especially because we get to find out more about our referrers, cases we've been treating, and really bringing them to life. So super excited to say we've got Dr. Usman Qureshi with us today. We've been working together for, many, many years now, I guess. Yeah. I don't know the exact number, but yeah, since very close to when we set up. And we've done a lot of orthodontic perio cases together. But before we start, give us a little bit of intro in terms of your background and your practice.
Yeah, thank you, Reena. Thanks for that welcome. I'm a specialist orthodontist. I've been in practice as an orthodontist for at least 15 years now. I trained as an undergraduate in Manchester University. I completed my postgraduate training at the Royal London Hospital, QMUL. And basically, I split my time between my private practice and my teaching role at QM, where I train postgraduates in orthodontics as well. And yeah, I love being an orthodontist. And certainly, I also like the multidisciplinary sort of orthodontics that I do. And so working with your team at RW has been great because you've got some forward-thinking periodontists, which really helps me in those kind of joint cases, really. So that's a bit about me.
Brilliant.
Do you need more?
I think that's plenty and very comprehensive. It's nice that you've got both the practice side, the teaching side, so you're always at the forefront of everything in dentistry. But I definitely think, I don't know what you think, but definitely the perio ortho kind of the whole topic, the number of cases we're seeing, it's definitely become more and more popular. Have you found that in your practice that you're leaning more to a periodontist now for more cases, and why do you think that is?
Yeah, I mean, I think adult orthodontics, if we start just from an adult orthodontics space, adult orthodontics has really grown over the last 20 years, let's say. Now, some of that's driven by cosmetic appliances and so on. But I think also increasingly patients are much more conscious of their overall dental health and general health. People want to be preventive in this day and age. They want to try and preserve their dentition, their general health as best they can. And so I think the motivation from patients is definitely improved. There are patients that don't want to just let biology take its course. They want to try and be proactive. They want to prevent progression of pathology and disease. They want to maintain a good, healthy smile. So I think that's a big factor, is that sort of mindset of the patient is improving. We're all a lot more conscious of our general health, and I think that's where it starts from. And I think with the adult patient,
I completely agree. I think aesthetics is still a big thing, but I definitely think at the forefront now, especially I found since the pandemic, health is still or is even more so important for patients, and they realize it's health first and then aesthetics and everything else. So yeah, I completely agree that has changed over time.
and the thing is with the health side of it, I think when it comes to perio patients, they've got a big journey when it comes to their periodontal and general health, and they've taken so much, they've invested so much in their general dental health and periodontal health that once they've got to that stabilized point, they're very motivated, and any other improvements that they could make, they're keen to achieve. So for some, it might be an aesthetic improvement because the teeth have splayed. But for some, it might be, if I can get my bite a bit better here, hopefully it will make my perio progression a bit easier. It might make my teeth a little bit steadier. So it's not just aesthetics anymore. I think there's definitely some aspect of it is aesthetic, but there are a number of patients that are looking to achieve a healthier bite and smile as well. And I think as orthodontists, we've perhaps been a little bit of a blind eye to perio, and but I would say there's a lot more research and studies now that have shown us that orthodontics can complement perio care quite nicely because it can help, improve reduce the progression of pathology if we can give our patients a better, healthier sort of position.
I completely agree. And I think we've had at the clinic for sure an increasing number of adult patients coming in and wanting orthodontics, actually not for aesthetics, but so they can clean their teeth better.
Yeah.
For example, lower incisor crowding is one of the number one reasons at our clinic why we refer often to you for the orthodontic side, because yes, okay, fine, they might not like the look of it, but actually once it's aligned, they're so much happier maintaining that. So I think often orthodontics is for health, not just for aesthetics as well.
Yeah.
And I think from the other point of view as well, like looking at it after the orthodontic journey, I'm finding more and more now patients will notice any recession, anything like that, which periodontists can help with in terms of grafting, and even beforehand being careful with what movements we're going to do to minimize recession, because I feel like patients are noticing even a few millimeters more so than before. So I think it's important to remember that it's the perio ortho journey. I think it's right from the beginning all the way to the end where we can help both specialties help each other.
And when it comes to grafting and perio, I think as orthodontists, and I hope there's some orthodontists that log on to this podcast, but we really get very little to no perio input in our training. And so you kind of develop this understanding from your patients as you gain experience and so on. And so we're very, if you like, we're not necessarily up to date with what's possible perio-wise.
Yes.
So when you talked about grafting, for such a long time, I recall in my training, the concept was that, grafting, it doesn't really work. It's not very stable. But I've seen so many grafts now where actually they hold fine. And it's not just that, they're unpredictable or they're unstable. There's going to be cases where, I mean, you'll know better than me, but there are cases where you can do it predictably and you've got a good prognosis. And I think so. I think that sort of awareness for patients that see periodontists is obviously there, and then they come to see us to try and help in that journey as well.
Yeah, I think that's a really important point. The number of people that still say to me, grafting doesn't work, and does it really last? And then do you get deep pockets? But I think things have changed over the last decade or so. The techniques we use, they're very predictable. And I think it's important, as you said, to be aware of what's out there, what is possible. It can help health, it can help aesthetics. So it's worth looking at. But as you said, and not just in obviously specialist training, but in undergraduate, we hardly ever go over recession and grafting options and what's possible. So I think there's a missing thing there in the undergraduate curriculum. I think there could be more on that, I think, for sure.
Yeah.
Going on to a case, this is our case discussion segment. So we've done so many cases together, but the most recent one, I guess, close to home is actually my mum's case. So my mum, she's 67. She's definitely in the adult orthodontic kind of sector. And just to give you some background, she was for many, many years really upset with the way her teeth look, the crowding, but also one of the major issues, which you mentioned at the start, was her bite. And because things weren't aligned properly, she was fracturing teeth, etc. So, I referred her to you a little while ago. But yeah, give us a bit of background as to kind of what you found in her case, and we've just about completed the treatment now. So what your kind of approach was with her.
Yeah, I mean, first of all, it's no pressure for an orthodontist to get a referral from a periodontist mother. So the pressure's on to preserve that the pink tissue there. No, that's for sure. But it's absolute honor and pleasure to have looked after your mum. She was a lovely patient, and it was a challenge. Like a lot of adult patients, people think about adult orthodontics and they think, 20, 30 somethings, or, trying to make themselves look a little bit better. But actually, there's a number of patients we see, like your mother, in their 60s. Even I think my oldest patient will be in her 80s. And the way you manage a patient with orthodontics at that stage is very different. We've got to treat the patient very differently. We've got to maybe have more conservative goals. We've got to be a bit more realistic. We've got to be considerate of the biology of the patient, because at that stage there will be age-related changes. There will be less bone around teeth. There will be reduced tissue points. There may be heavily restored dentitions. Our older patients won't have had access to the type of dental care we've had access to. So you really have to wear a different cap. As orthodontists are very pedantic, and they're very sort of focused in terms of certain set occlusal and alignment goals that they want to achieve. But you really got to try and find a compromise. And I think it's about finding a compromise that works for that patient's biology, but a compromise that fits in with your patient's goals as well. So you've got to sort of change the boundaries a little. And we had to do that in her case because she had quite a significant malocclusion. It was a 2-div 1 deep bite situation, with quite a bit of crowding and some soft periodontal tissue loss as well. So, I had to be a little bit conservative. Indeed, we've achieved alignment, and we did so on a non-extraction basis. And if I'd seen her as a teenager, I maybe would have thought about extractions. But when you've got heavily compromised teeth, you try to preserve and work with everything as best you can. And maybe you don't fully correct the overbite. Maybe you don't fully correct the overjet. But at least you're achieving that improvement in alignment, which aesthetically helps your patient. But if you're getting some improvements in the occlusion, well, hopefully now the teeth aren't loading as heavily. Maybe those restorations ain't going to be so prone to fracture. Maybe, so like in your mum's case, when Sahil does a replacement crown or what have you, perhaps the occlusion is a little bit more favourable now.
Yes.
So it's all a different thinking cap that you've got to put on, which, again, you don't get taught in orthodontic school, where you're predominantly treating young, healthy children. And so that is definitely a different type of orthodontics that needs a different approach, basically. And I hope she's pleased.
She absolutely is. She's over the moon. And I think that, as you said, it was a challenging journey for yourself, I think, and her as well, because I think at that age, adapting to, especially she had fixed ortho, it's a real, it's not easy.
That's a really good point, adapting, because when we treat kids, they adapt every single week to a change in their life. A baby tooth's come through, the gum hurts, another one falls out, and so they're used to constant change. And even 20-year-olds and 30-year-olds, their biology is still pretty adaptable. But with an older patient, some of the challenges are things that we get away with in a young child we don't get away with in an adult. So, for example, I think if you remember, we used bite turbos at one stage to help the overbite, and she found it really uncomfortable. And she persevered, but we had to reduce it. And so there has to be some greater compromise by the orthodontist, really, in the way they do things.
For sure. From my side, from the perio sort of point of view, I think, and we see obviously lots of patients who want orthodontics, and often, you're sending patients because they come to you first, but their periodontal health is not stable. I think it's really important to highlight that before sending someone to an orthodontist, you really want them as periodontally stable as possible. And we are very strict on that. And as much as possible, stability is basically no probing depths of 4 millimeters and above with bleeding. And someone's oral hygiene needs to be at a decent level. Like, I think it's obviously dependent on the patient and how much they're trying, but otherwise, there are serious risks doing ortho. We've seen the other side of things where patients come back and they've lost multiple teeth because of orthodontics, and they say, I wish I knew the risks. So I think be strict. If your patient is thinking about having ortho, but they've got perio, get that sorted first. I think it's really important, and patients are often pushy, I guess, because they've got a wedding coming up or whatever else. But I think it's worth adding on a few extra months, getting the perio sorted, and then completing predictable treatment. Because I'm sure if the perio is, wildly out of control, the orthodontics is not going to last either. You're not only going to lose teeth, you're probably not going to have that stability in the end.
Yeah.
From our point of view for my mom's journey, we did so we got her as stable as possible, sent her to you. And then for every patient in this kind of situation, it's really important to do maintenance as well. So I think some of the reasons why the case was so successful was those rigorous 2-3 monthly maintenance appointments with the hygienist, us checking the probing depths, every time, doing formal pocket charts every 6 months. And I think the communication between both specialties is really important as well, so that we can stop and, as you said, edit the plan as needed.
Absolutely. And as an orthodontist, we have to listen to our periodontist. And we're talking about your mum's case, but there've been other cases where you've stood your ground and been very clear to us that, look, I don't want you progressing. And I think as an orthodontist, if your periodontist is saying to you, you need to pause here, I don't
Yes.
want you to put active forces on, you've got to be able to adapt and do that. And we've had to do that where, as
Yeah.
much as the patient is pushing for us to continue and progress, we've had to say no. Dr. Reena is looking at your best interests, and if she's saying pause and stop, that's what we need to do. And you have to be able to put the brakes. And I guess as an orthodontist, try and communicate the periodontal aspect, which is difficult for us because we're not, we're periodontally partially sighted, I'd say.
Mhm.
But we've got to try and be able to relay that message and reinforce that message. And I guess what I would say is, since I've got to know you, Reena, I've come to quite a few of your study clubs and so on, and that's actually helped my own perio knowledge,
Mhm.
which has helped because I feel I'm a bit better informed now, sort of reinforcing messages and that kind of thing.
Yeah, no, for sure. And I think it is difficult though, isn't it, when the patient's pressurizing you and they're like, I'm
Yeah,
happy to take the risks, and they really want to. It's a very sticky situation, I think.
yeah, absolutely, um, and I think that needs teamwork really, and everybody being on the same page. And when we've had cases, I think in your with one of your colleagues, where we've also needed the help of an endodontist as well, because you can get perio endo problems.
Correct.
And that's really important that everybody then is on the right page, whether it's ortho, perio, endo. And that's, yeah, it's good when that happens, I have to say, because dentistry is really stressful. And some
Yes.
of these cases are tough, they're difficult, there's
Yeah.
higher risks involved because they've got more compromised teeth that we're working with. But
Yeah.
having that sort of team approach, I would say, has made my management of some of these quite difficult cases less stressful. Because I know there's a lot of orthodontists out there say, no, you can't have orthodontic treatment, or it's too much hard work, and they maybe don't want to do the treatment for that patient. Whereas I think because I feel like I've been quite well supported by your clinic and your periodontists, and that's made it less stressful for me to sort of work on these cases with you.
Thank you. And I think it's nice that, as you said, it's all about communication and making sure that everyone's doing the right thing in their role, essentially. And when you can, I think you can really push the boundaries as well. I mean, we've had some cases where we have treated patients with quite severe bone loss.
Yeah,
We've managed to get the outcome for them. So it's not to say that periodontal patients with severe perio, even stage 4 perio, can't have ortho. They can. It's just how you do it, and
sure.
being aware of the risk. The consent side is really important for the patient as well. And then, as you said, like knowing when to pause or even like stop the
Yeah,
treatment fully. And I think that is one of the most important things. People think, oh, there's only a few months left of the orthodontics. I'm just going to, even though the perio has now gone out of control, I'm just going to finish it. But no, you've got to stop, get it treated, get the perio under control, and then maybe recommence. And I think that, as you said, is the stopping and starting and editing the plan. It may not go perfectly, but you've got to make sure you're careful at each stage. And
yeah.
that's why we're involved as professionals. And it's
And
not.
what I find quite helpful with not just either from your, but with any periodontists that I work with, is when they share their pocket charts and their bleedings, because we wouldn't know how to record that in that level of detail. That's really powerful and strong stuff for us as well. So when that's shared, at the point of initial consultation, that's such a powerful consultation for me, in the sense I've got so much diagnostic information.
Yeah.
So I think that sharing of clinical information is really useful. I mean, there've been times where I've had to video a defect and send it over because actually I wanted to show a degree of mobility in tissue or what have you. So I think just using good comms between clinicians is definitely going to support the diagnosis and the patient outcomes.
And what's been kind of from your sort of the biomechanic kind of mechanical point of view, like what has been key in these style of patients, like in terms of force levels, etc.?
Yeah, so I think, you've got to be gentler, so you've got to use lighter force levels. You've got to certainly set your goals a little bit more conservatively, maybe not try to do very extensive occlusal changes. I think when it comes to the type of appliances as well, I find actually it's not that you can't treat patients with aligners in perio, but sometimes a fixed appliance could actually be gentler on them because there's less jiggling forces. And so it's sort of weighing up the risks of which type of appliance to use.
Yeah.
In terms of when I'm doing treatment, I try where I can to avoid overuse of elastomeric stuff because that attracts plaque more readily.
Yeah.
I normally wash things down. If I have a fixed patient, I will actually take the wires out and jet wash things. It's not going to be as good as a complete biofilm removal, but these are things that we can do to help you guys because your hygienist will be looking after our patients when they've still got everything in place. Whereas when I take the wire out, I can certainly get in there and try and reduce some of that biofilm. I even have a hand scaler. So I do use a hand scaler when I've got, because sometimes around brackets or even around attachments, it's very difficult for the hygienist to actually get access to those things. And when you've got them in the chair, just take that 5-10 minutes to just help that journey along. Because if everybody's doing a little bit, it's going
Yes.
to help the patient. And so those are sort of key things. I try not to put too much torque into the patients, and torque is to do with the root crown ratio
Yeah.
movement because that requires quite heavy forces. And just really keep things as gentle as we can, really. And what I also notice is that teeth do move a little bit quicker
Yes.
because the bone levels are less. So I might see the patient with a higher sort of frequency, and maybe I will see them 4 weekly, not 6 or 8 weekly, which might then also mean I can freshen them up a bit more. Do
Yeah.
you see what I mean? So just small things, nothing major, if you like, but all these little small gains hopefully keeps the patient progressing nicely.
For sure. I think, yeah, definitely the kind of slow movements, even if they are having aligner therapy, like we sometimes often say, like double the number of aligners, just take your time with it. But as you said, yeah, I mean, the advantage of a perio patient is that they got less bone, so things move quicker and
Yeah,
the plan is shorter
I guess
sometimes.
there are some things that which orthodontists might be aware of, but sometimes we will be putting preference on the position of a root over the actual position of the crown. So if we have a patient that's maybe got recession, we
Mhm.
might choose to align the teeth, but put priority on the root alignment as opposed to the crown alignment,
Right.
because we want to try and position that root as favorably as we can within the alveolar ridge to
Yeah.
support whatever grafting is happening. Now, that might mean the tooth appears a little bit misaligned
Mm.
from the surface, but actually biologically it's in a better root position. And then you can always do something like contouring or touch things up afterwards to try and mask it. So that's kind of some of the variations that we do.
And what about retention? What's been your most successful, I think, for perio patients? Do you advise fixed plus removable, or what's your protocol?
So definitely I would be aiming for fixed because they've already got reduced support levels. And when we use the fixed retainer, in some cases where you've got periodontal mobility, I almost view it as it's almost like a periodontal splint.
Yeah.
So if I know there's quite a bit of mobility in the tooth before we enter into retention, I might even put double retention, where I
Mm.
put 2 fixed retainers to try and reinforce the stability of the tooth. So that can work quite well, especially in patients that have got spacing, because space is trying to open up. And then I normally do reinforce that with a vacuum form retainer over the top. But the vacuum form retainer is an important bit because with perio patients, you have a lot more recession. Therefore, you have a lot more undercut. So my team, we design all our own retainers here in the house using our 3D printer and our software. But despite all that technology, we still got to do the basics, which is inspect the models, block out undercuts. So I think it's very important if you're using an external lab that you ensure that those undercuts are blocked out. Otherwise, it's very difficult for a patient to insert and remove their retainer. And you also, as my final tip, you want to make sure that that margin of the retainer doesn't impinge on the soft tissue. Now, normally as orthodontists, we like 1 to 2 millimeters of gingival extension of our margin for more to get a more rigid plastic, to get a more sturdy retainer. But actually, the perio patient, where you've got undercuts, the more cervical you go, you've got the possibility of impinging on delicate tissue. We will cut it short. And there'll be cases where you might have that margin resting midway over the crown of the tooth, which would maybe look unusual to a dentist or a colleague if they saw it. But the rationale for that is to try and make sure that that retainer doesn't cause any sort of iatrogenic harm in the retention phase.
Yeah, makes complete sense. So yeah, I think the whole approach for a periodontal patient having orthodontics is quite different to your
Yeah.
standard child, patient for sure. No, I mean, all the care you've given to all of our patients has been absolutely brilliant. And I think, as you said, the key thing has been that communication and having an open mind as to how we can, and sometimes being creative about a treatment plan as well. One thing I want to talk about before we finish is wire syndrome. I'm reading more and more about this. In fact, so we published a paper on this recently as well, and it's a topic which not many people know about. So, whilst we have you on the podcast, tell us more. Wire syndrome? What does it mean? And yeah, because it's definitely one of those perio ortho
Yeah.
collaborations as such.
So, I mean, I think it's something now, I'm actively trying to educate my patients about it because, fixed retainers have been with us for many years,
Yes.
40 years since it was first published as a technique. And so there's a lot of wires out there. And orthodontists have been using fixed retainers for several decades now. And they're designed to last, but they don't last forever, and nothing is infallible. And we know from clinical patients coming through, but also from the literature, that sometimes these wires might break, sometimes they become distorted, or the composite detaches, and at that point the wire becomes active. And a wire is what we use to move teeth, so it can
Yeah.
move teeth. And I guess my experience of it, every orthodontist wants to believe that none of their wires fail. And I can say I've probably not been around long enough to see my wires fail, if that makes sense, because the wires that I see failing are usually wires, 15, 20 years old, or they're someone else's wires. So I believe my wires don't fail. But we don't know because, patients move on in life. They're 18, they move to a different country, different part of the world. So you're never really going to know. But the literature tells us it's happening more than we thought. So certainly I would say to my patients, look, long term, we think that perhaps 10 to 15% of these wires become active. And so, I do have to I'm in an established historic practice in the West End, which has been there for many years. So we do see patients at 20, 30 years, like my predecessors' retainers, and many are fine, but some are not. And those that are fine, we still have to caution the patient, look, this could happen.
Yeah.
So I think it's awareness is the first thing,
Yeah.
and then it's making sure you make decisive steps when you do notice it, and that's the other side of it, really.
Yeah, and I think I would definitely advise all of our listeners to read up more about it.
Yeah.
And I think the more you understand it, the more you might actually start seeing it in practice and be like, oh, okay, that's maybe wire syndrome. And then involving, in terms of the ortho side, perhaps, changing the root position, as you said, prior to grafting and considering all those things to get the best outcomes.
And
Yeah.
I've been thinking more and more, Reena, that often the dentists themselves may not necessarily see this because if they've got a stable, healthy patient, they may well be seeing their hygienist for their routine cleans. And so I think it's something that the hygienist
Yes.
colleagues of ours need also to be aware of because they are actually probably looking at these things a lot more than the patient's dentist. And so I think there is a need to maybe raise awareness with the hygienist as well. I mean, actually, even the patient today who's come to see me, who's come for a routine retainer check, but it's the hygienist that says, "Oh, could you just mention to your orthodontist that maybe the bonded retainer's just worn a little bit?" So that's good practice, I think, as well. Sort of just if we can maybe encourage and educate, maybe from your side or as an orthodontist, just to raise that awareness with our hygienist teams as well.
I think that's a really key point. And I guess they are the ones looking after the patients more often than and seeing them more often than the dentist. So thank you so much, Usman. I could talk to you for much longer on this topic. There's so much to discuss, but I hope that gives us, our listeners, a little insight into the perio-ortho sort of collaboration. And I think definitely you get better outcomes when they are aligned from the start, no pun intended. But yeah, I think you highlighted the importance of realistic goals, gentle forces, monitoring, and communication being sort of at the central part of everything we do. And I think patients will notice that when various specialties are working together. At the end of the day, we've got to put our patients at the center of everything we do, and doing it to get the best outcomes for them in the safest, most effective manner. So thank you so much for sharing all of that. Looking forward to treating many more cases together.
Lovely. Good to see you, Reena.
Thank you.
Everyone, this is Dr. Sophia and I'm with Perio School today. Today we have our dentists for the Diploma course and their topic is the crown lengthening technique. So today we would like to find out and ask them a question. What is one thing that they have learned today that they will take back to their practice and that will change the way you approach perio cases or perio patients? So let's see what they say.
The importance of good planning for these cases to be successful.
Using the curette with the modelling of the bone for crown lengthening at the top edge worked really well.
The question is, what is one thing you learned today that will change your practice? You will take back with you to your practice and then change your approach?
The different types of sutures and when to use it in terms of aesthetics or function.
The learning about bone and all the different ways of you don't have to use the motor for everything and actually it can be quite delicate and quite controlled. I didn't know that before.
Probably soft tissue manipulation.
Thank you very much, everyone. As you can see, that was really, really insightful. And you see that our delegates of Perio School are really enjoying the hands-on course today. They're busy with working on pig's heads and practicing new techniques of crown lengthening. Well, these are the inside, but make sure you'll join our diploma next year and you will be able to have the same wonderful experience that they have with our hands-on courses.
We are so excited to welcome into our quickfire My Dentistry Life Q&A Laura McClune. Laura is a dental hygienist and an experienced dental professional with a diverse background in the dental field. Graduating from King's College London in 2005, she spent many years in a variety of general dental practice settings before taking her career in a slightly different direction, working with industry and higher education. In 2020, she went on to gain an MSc in Advanced and Specialist Healthcare from the University of Kent and was elected as the Honorary Treasurer for the BSDHT. Most recently, she worked as a Dental Care Professional Teaching Fellow at the University of Portsmouth, teaching on the undergraduate dental programs. Whilst at Portsmouth, she was awarded a research fellowship by the NIHR and was a recipient of the Colgate-Robin Davies DCP Research Grant. She has also contributed to other local and national oral health research, coaching and mentoring programs, and has been an active member of dental stakeholder working groups. A passionate advocate for lifelong learning, Laura is deeply committed to empowering others through continuous personal and professional development. She is due to start a professional doctorate in education at Nottingham University this year. In her current role as Education Manager for Professional Oral Care at Colgate, Laura is responsible for all things student engagement and education. Wow, Laura, what an introduction. I mean, you've done so much in your career. Official welcome to the Perio School podcast.
Fantastic. Thanks so much for having me, Reena. I think when you read that out, it's like, oh, I can retire now. I can finish. Life made.
Absolutely. I mean, what an impressive background. And I think it's so great to have you on the show. And it's so wonderful to see, the way you've taken your career. You've not taken the kind of usual pathway of a dental hygienist. And it just shows, doesn't it, that you can really mold your career however you like and introduce many other scopes to your practicing life.
Yeah, I think when you first graduate, I mean, for me, it was a long time ago, you don't realise that there's so many opportunities to have. You think, oh, I'm just going to be a hygienist in surgery, cleaning teeth, which is amazing. It's fantastic. I've always kept up my clinical work alongside my other sort of adventures and ventures. But I think once you grow and you develop and you learn these skills, you realise they're very transferable. And if you are someone like me that gets quite bored, and I think my CV kind of shows that, is there's lots and lots of ways you can kind of use these skills and do other things to still make an impact to people's health and well-being.
Yeah, I don't know if bored is the right word. I think motivated and, want to get out there and try different things. So I think it's absolutely amazing. So this is one of my favorite segments of the podcast, and it's a quick fire round of some interesting questions and hopefully some interesting answers. So we'll kick off with, how do you start your day? What's your ultimate morning routine?
I'm probably quite annoying in the morning. I'm a very morning person, so I love to be up early. I think it's a really precious time of the day when you get up. I don't have children, so for me, my mornings are probably quite peaceful. But to kind of get up and there's no one around, it's quiet. I live in the countryside as well, so to get outdoors and really, even if you don't really feel like it, I like to get up, get outside, or go to the gym. I think for me, I have to start the day with some sort of exercise, more mentally than physically, just to really clear my head. I'm a bit of a thinker. I do a lot of my thinking when I'm exercising and when I'm walking. So I've often got my notes section out on my phone and I'm jotting things down when I'm walking along. So it's important to kind of get up, get out and get motivated for the day.
Nice. And I guess a lot of people say they get their best ideas in the morning. You've got that clear thinking.
Yeah.
And wow, being in the countryside, that must be really nice, just getting out and getting some fresh air.
I
And
think give me a few hours into the morning and I'm not really good for anything. So if you want something from me, catch me first thing in the morning.
in the morning.
Yeah.
There we go. And what about breakfast? What's your kind of ultimate breakfast for the best energy and performance throughout the day?
I'm someone that always eats breakfast. I think my friends and my family just find it really strange. Even if I'm going to the airport at like 4 o'clock in the morning, I'm like, have to have breakfast, have to have something, have to start my day, because I get very miserable if I'm not eating and I don't sort of control my blood sugar and things like that. So depends on the season and the time of year. At the moment, it's very cliche, very trendy. Overnight oats is what I'm having. I generally tend to I like a bit of protein with my breakfast. So oats, chia seeds, and yogurt and nuts as well, and lots of berries. I'm obsessed. I must spend an absolute fortune on berries from the supermarket, but just something that's really going to kickfire me. But when it's colder, and like today, it's feeling very autumnal, it was porridge, but usually something oats based. But I have to have breakfast. I'm good for nothing if I don't eat. I'm very miserable.
Love it. Very similar to mine, actually.
Yeah.
3 things we can always find in your work bag. I know, obviously, your routine will be different every single day depending on where you are, but what are those essentials that you always have?
My work bag is a bit of a mess, to be honest. I'm a bit of a handbag hoarder as well. I've got so many different bags, but always my work bag is my presentation clicker. So I deliver a lot of education sessions and I'm a bit fidgety when I deliver sessions. So I like to walk around. So for me, if I'm away from the lectern and the laptop, I need my clicker to be changing slides and pointing things out. So that's always with me. That's a non-negotiable. It's a bit geeky, but that's that. Usually a notebook. I still love pen and paper. I still love writing stuff down just to jot my ideas and thoughts down, and then I can kind of relax and move on. And always a lip balm. I just like a really nice lip balm because I'm always talking. So I find that my lips get really, really dry. So very boring, probably, very kind of predictable for someone that works in education. But those are my kind of things that are always in my work bag.
No, I think all sound very, very important and essential for a good day ahead. And in terms of technology, so I don't know how much of a phone app person you are, but what would be your current kind of favorite app or most used app at the moment?
Yeah. It's got to be Google Maps, because in this role that I've got now for Colgate, I look after the whole of the UK with regards to dental schools. So I'm often going to new places, new destinations, which I absolutely love. It's a real pleasure to kind of see new things. But I get lost quite easily. So I'm very much a planner. I've got Google Maps. I've mapped my route, my kind of journey, what sort of transport I'm using. So Google Maps is something that I'm always using. On the other hand, I'm trying to embrace AI quite a lot. I'm still sitting on the fence slightly with it because I'm still a writer and a reader, and I love doing things myself. But Google Gemini is always open on my work phone in particular, just for kind of quick things, ideas and things like that. So I'm trying to embrace technology, but definitely Google Maps for sure, and Gemini as well is really, really useful.
Brilliant. And we spoke about your kind of overview of your career, but what would you say you're sort of most passionate about advocating at the moment?
For me, it's got to be lifelong learning. I think I've got an awful lot from doing courses, from kind of going to sort of events and even reading and stuff like that. I think because you automatically think when you go into the career as a dental hygienist that's it. You're just going to be cleaning teeth day in, day out. But obviously we have our continuing professional development to be doing. That's an obligation from the GDC. But for me, I'm quite nosy. So I love to learn. I love to kind of keep reading. And I really encourage other people to do that, even though initially there's no real tangible kind of result from it. A lot of people, when I've said I'm doing a master's or I'm doing these courses, well, it's not going to earn you any more money. But no, it's going to be fulfilling. And it's not always about earning more money. It's about what can you offer more to your patients, your peers and others within the profession, which is why I love working with students. And I always encourage people to keep learning and keep developing yourself. And that's hence why I've done lots of different things with my career.
I mean, I completely agree. I think investment in education is never a waste. It always brings back something in one way or another. I mean, you've done so much so far, and you mentioned to me, 20 years, maybe another 20 years to go, which will be really impressive. But what will be the current highlights so far out of all the different roles that you've done?
I've been very lucky. There's been lots of different things that I've kind of been able to, opportunities and things that I've achieved. But I think for me, it has to be my master's. So I've been out of education for a long time. I've been working in practice and dedicating to my clinical skill, but I was getting a little bit fidgety, a little bit bored, wanting to do a little bit more. So for me, the master's has to be the biggest achievement that I've done to date. I wasn't very academic. I was average. I think I just scraped through my dental hygiene diploma. I think I got 1 mark over the past mark. So it was a bit daunting to go down the route of doing an MSc, but the environment that I was in, my tutors, the teachers, the people that led the course, I really flourished on it. So I found that this is actually something that I love. I love academia. I love learning. I love research. As tedious as it can be sometimes, that was amazing. For someone that hadn't done any sort of academic work, I don't think we even had computers when I did my undergrad course. So it was all new skills to learn, and doing it alongside working full time. Amazing. I think for me, the MSc has got to be up there with what I've done.
So here's a tricky question. How would your colleagues describe you?
It's interesting because I work remotely, so I don't often get to see a lot of my colleagues. So often it is just me at home. But yeah, they'd say I was quite introverted. So I think you tend to find a lot of people in the dental profession or healthcare professions are slightly introverted. We've got that kind of that mindset, but you're forced into this world where you're kind of entertaining your patients. You have to be upbeat and out there with them. So yes, I think my colleagues would probably say I'm slightly introverted, maybe a little bit kind of quiet. They might find me slightly annoying because I like a lot of detail. So we do something within the business and within HR, which is called Insights. And it's basically gives your personality by a series, it's like psychometric sort of testing, gives you colours. So the colours are red, blue, yellow and green. I'm actually a blue, which is someone that's very analytical and requires a lot of detail. So if someone fires an email off to me that's got no detail or that's very kind of short, I'm always asking for more. So I'd say maybe they find me slightly annoying because I'm like, but what do you mean by that? I need more information. So I'd like to think they think I was approachable as well. I generally try to be quite relaxed and upbeat throughout the day because there's usually always a solution to the problems as well. And I don't like to kind of feed that into other people. So I'd like to think that they'd say nice things about me, but Maybe you can ask them.
No, I'm sure it's positive. How would you describe yourself in one word?
This is really difficult, but I think kind. I think if anything I'd like to be remembered for, I'm always thinking of other people, and I would like people to think I was kind. So whether it's patient focused, peers, friends, family, I think it's important how you have that impression on other people, how they feel. So for me, just always be kind. There's no need to be mean or horrible to people. If people remember you as kind, then that's always a good thing in my eyes.
Love it. I love that. You've spoken about, you're a big advocate for professional development, being approachable for everyone. And what about personal development? What would be because clearly your personal story is super impressive. What would be your best tip for that personal development side?
Don't do it. No, I'm joking. No, I think it's really important to have that element of self-reflection. I think there's lots of courses out there, there's lots of opportunities, lots of options. And I think students especially get decision fatigue. As professionals who look, what should we be doing? I think really understand yourself and what you want and what you're going to get out of it, because it is your journey, it's personal to you. Don't compare yourself to other people, and really think about, actually, what do I really enjoy? What do I really find interesting? Because if you find something interesting, you're more likely to stick at it. So for me, I think definitely understand yourself and self-reflection. You have to embrace change. Change is something that I thought I hated, but if I look at my career and I look at what I've done, I've changed quite a lot of things. And I think if you don't like it, change it. I know it's difficult, but there are always options. But you have to, in the dental profession in particular, embrace uncertainty and change. And I think if it's not working for you, there's got to be another route. There's got to be something else to explore and have a look. But ultimately, I think seek out others. You can't do this in silo. You can't do this alone. There's lots of other people that have kind of walked these paths and kind of develop themselves individually. So I always look for others with similar mindsets or similar career trajectories, or even different things that I'm interested in, because I'm a big advocate for coaching and mentoring, and big advocate for learning from others. So find other people that have the same interests and passions, because it's infectious. And then you should find that helps to kind of steer your journey into an interesting way.
Brilliant. All makes sense. Really, really good advice. And I mean, you've given us so many pearls of wisdom already, but do you have like a favorite life quote that you always kind of remember in tricky times, or to keep you going and motivated?
Yeah, this always makes me laugh, because I'm very sometimes going to be a little bit fickle and a little indecisive, so it depends on what mood I'm in. I look at some quotes someday and I'm like, oh, that's rubbish, but then other times it really resonates with me. I always remember something my mum said. So she had some really funny anecdotes and quotes and things, but this one in particular seems a bit strange. Basically, she always used to say, when I was upset or there was something going on and I thought there was no solution, she always said everything would have come out in the wash. So it's not to do with laundry. It's basically about, it will all be okay in the end. There's always a solution. There's always something you can do. So for me, it's not about all the big kind of affirmations and quotes and things. It's just things quite simple. But yeah, usually everything does come out the wash.
And that's something that would help, day to day as well. Sometimes it's not, as you said, the big affirmations, big, wild quotes. It's actually the ones that will help you minute by minute every day. Yeah. So no, I love that. The mum quotes are always the best. I'll quote you from mine. So let's talk about sort of, off-duty things. Where would be, you mentioned you're in the countryside. What's your kind of ideal spot when you're relaxing and not working?
Generally, it's actually inside. It's yoga. For me, I started practicing yoga probably about 5 or 6 years ago, when I was under quite a lot of stress and there was a lot going on. And I think for me, that is something that I don't do enough, and I don't have the opportunity to kind of practice as much. But no matter how you feel, if you show up, yoga class, it will always make you feel better. So that for me is my happy place. Or outside, like I said, I horse ride. I like to be out in the countryside. Yeah, kind of two contrasts, but yoga for me has been something mentally as well as physically, which has always been there. And that's always helped me kind of move through difficult, challenging situations.
And would you say you're a more music person or podcast person?
Again, it depends on my mood. You'll see a different me 10 times in the day, to be honest. But music, if I'm in the car or I'm exercising, I'm terrible on that person with my music up quite loud, which I wonder why I've got tinnitus now. Is it because of the dental equipment or is it because of the loud music? But I do like podcasts, but I really like listening to other people's opinions and stories and views of things. So podcasts for me are really important. The only downside with the podcast is if I hear something interesting, I'm like, oh, I want to make a note of that. But if I'm walking, it's quite difficult to kind of record things like that. So again, it depends on what day and it depends what kind of mood I'm in. If I want to blow the cobwebs away and kind of feel good, it's usually loud music.
Nice. And which TV show would you most like to guest star in?
This makes me laugh. I don't know whether I want to be famous. I don't think I want to be recognised by someone, be like, oh, you're in that TV show. But again, I like crime dramas. So maybe some sort of like hotshot detective or something.
Yes.
I don't know. But a lot of these crime shows have amazing backdrops. So again, you'll see the theme of countryside somewhere in the Scottish Highlands or something, somewhere really beautiful where people are getting brutally murdered on the other side of things. But I think, some sort of crime drama. I'm not entirely sure what one, but again, I kind of sit on the fence about being famous. I don't know whether I'd enjoy that.
And how do you stay motivated then? Is it through, the yoga, the exercise, music? Like what keeps you motivated throughout the day? Especially because you then are, often working alone and not in that kind of office environment.
Yeah, it can be really difficult. And I think I'm going to be brutally honest. Some days I'm not motivated. Some days I'm like, oh, I really don't want to do this today. But I think it's priorities and it's making sure that you achieve something. Even if I achieve maybe designing a new presentation or sending a few emails, what small wins are really, really important because otherwise you can get derailed. If you look at the huge picture, and I'm very guilty of looking at the end result and where I want to be, but I think to stay motivated, you have to be focused. And there is an element of discipline. I've got a little bit of a mentality that unfortunately hard work is necessary. If you want to do anything, it's almost like eat the frog, isn't it? You've got to get that task done. But equally be kind to yourself because some days you're not going to be productive. You're not going to be motivated. And if it's enough just to go to the gym or do something small, then that's absolutely great. But again, as I am an introvert and I do spend a lot of time by myself, it's very easy to kind of get into that mood and that mindset. So back to surrounding yourself with others. Sometimes all you need is surround yourself with others who are motivated, others who are doing things. And sometimes a little bit of competitive jealousy is quite good to motivate you to do stuff. So I think be kind, don't be too hard on yourself, but sometimes you just got to get it done and look at the end result and look at what you could achieve.
Brilliant advice. Did you always want to be a hygienist? What profession did you want to be when you were a child? Did you know what you wanted to do?
I had no clue. I really had no clue. I was very, I loved animals. I was very outdoorsy. I was very studious. I was incredibly nosy as a child. I was always, why this, mum? Why that? All these questions all the time. So there was probably different things in my life. Maybe I think I wanted to be a librarian because it was all very organised, very meticulous. History, I love something to do with the history. I don't really think I even thought about healthcare professions until I kind of did my GCSEs and then moved to thinking about A-levels. And I ended up not actually wanting to do A-levels. And my parents said I had to get a job. So for me, I was looking at healthcare routes and it was dental nursing, which came across, which I thought, oh, that looks really interesting with people. It's kind of a job that has prospects and kind of movement forward. But hygienist never, ever came up at all until I started doing dental nursing and I wanted more autonomy and more responsibility and I wanted to have a bigger impact on the day-to-day patients who came into the surgery. But yeah, maybe I would have been, like I said, a librarian or something. Don't know.
And now looking back, like any advice that you'd give to your younger self?
Don't take yourself too seriously. I laugh a lot, but I do generally take myself quite seriously. There's lots of things that I've probably missed out on because I'm very much move on to the next goal. I want to achieve this. I laugh when I say I want to collect qualifications, which I tend to kind of do, but I forget about how I got there and the process. And it's very cliche, but enjoy the process, enjoy the actual moment of that journey because it won't get back again. So I think that was what I would say to myself. Don't take yourself too seriously and actually enjoy that process before the end goal.
And final question, what are you most looking forward to? What do you have coming up next?
It has got to be my doctorate. So I sound like a terrible geek here, but it's something that I've always wanted to do. I kind of got the education, the academic bug when I did my master's. So for me, I look to think is how can I be the best at what I am? And the way through that for me is knowledge. So if I can gain as much knowledge as possible about education, because my professional doctorate is going to be in education, how can I bring that back to my role at Colgate? How can I help students? And that's ultimately what I want to do. I want to know everything there possibly is about education so I can kind of learn and grow and bring that back. And I'm really excited to start that. Probably ask me 3 weeks in and I might be crying because it's a lot, but it's a part-time doctorate. So I will be doing that alongside my studies. It's something that Colgate's very supportive of. So
Amazing.
For me, if I can learn and grow and actually give that back to kind of students and look at it from an industry perspective, I'm excited. I'm probably not excited about writing 60,000 words, but I'm very much looking forward to seeing how I can develop myself and how I can bring that back to what I'm doing now.
I'm sure we'll get you back as Dr. Laura once you got your doctorate and you can tell us how it all was. And I'm sure
about 8 years.
8 years, wow, okay. Laura, thank you so much. What an inspiring conversation. Thank you so much for sharing all of that with us. I'm sure our listeners will be absolutely thrilled to hear the conversation. Where can we find you if we want to get in touch with you? What would be the best platform to drop you a line?
I would love to say Instagram. I do have an Instagram account, but I'm terrible on Instagram. But you can find me, Laura_education manager on Instagram. Email as well. You can find me through there. You can drop me a message. I know students use a lot of Instagram.
Yes.
So reach out to me on there or find me through the Colgate Professional website as well.
Thank you so much. And looking forward to catching up again soon.
Brilliant. Thanks so much, Reena.
This season of the Perio School podcast is sponsored by Colgate. Register on Colgate's professional education hub to access all professional and patient resources, including your one-stop shop for all verifiable ECPD. Visit www.colgateprofessional.co.uk today to sign up and register.